Hello, my name is Yancey E, and I'm a PGY4 General Surgery resident at Caroline's Medical Center in Charlotte, North Carolina. I'd like to thank you for giving me the time to present today. I'll be talking about emergent ventral hernias, and specifically the identification and analysis of risk factors associated with mortality in our regional emergency general surgery network. I have no disclosures. Approximately 10% of all ventral hernias require emergent repair. Patients undergoing emergent repair of their ventral hernias typically have worse outcomes. And this is typically because they have characteristics known to be associated with worse outcomes, such as older age, female gender, increased BMI, lower socioeconomic status, Medicaid or other government insurance, and larger hernia defects. These patients also have a higher incidence of significant unmodifiable comorbidities, such as CHF, COPD, peripheral vascular disease, and liver failure, just to name a few. These combined typically result in a much higher risk of 30-day mortality, postoperative complications, readmissions, and reoperations in this patient population. So why don't we just repair everyone's ventral hernia and prevent an emergent ventral hernia repair? Well, patients aren't healthy. And so a philosophy of watchful waiting has developed amongst this world of surgery. That is done to medically optimize our patients so that we're not doing an elective repair in a suboptimal patient. However, 40% of patients undergoing preoperative optimization end up presenting with incarcerated or strangulated ventral hernias that end up requiring emergency repair. This faces the surgeon with a dilemma. Do you optimize your patient and risk the 40% risk of having an emergency repair, or do you repair your suboptimal patient? For this reason, we conducted our study. We were attempting to define the burden of all emergency ventral hernia encounters in our regional healthcare system, as well as identify specific patient and operative factors that were associated with increased mortality in patients with ventral hernia. We looked at our large medical system, Atrium Health, and we queried it for AAST, EGS, ICD-9 codes for ventral hernia, which are listed on this slide. We queried our database from January 1st, 2013 to October 1st, 2015, which is when ICD-9 switched to ICD-10. We only looked at patients that had inpatient or observation admissions, and we only looked at emergency or urgent admission types. Exclusion criteria are listed on this slide. The variables we looked at were age, sex, BMI, comorbidities, Charleston Comorbidity Index, transfer status, resuscitation requirement, length of stay, discharge disposition, ventral hernia type, and type of surgery performed. In our analysis, we attempted to answer multiple questions. Some of those included the regional burden of ventral hernia, who requires an operation, what type of operation are they requiring, and are there specific risk factors for mortality? When we initially queried our database, we found over 250,000 patients with an EGS diagnosis code. 103,000 of these had inpatient or observation encounters, and 60,000 of them had emergency or urgent encounters. Ultimately, after applying all of our inclusion and exclusion criteria, we were left with 1,390 patients with ventral hernia diagnosis codes and 1,393 individual ventral hernias. These are some of the patient characteristics that we found of our cohort. The average age, BMI, Charleston Comorbidity Index, and length of stay are all listed, as well as the discharge destination. Majority of patients went home. However, a good chunk of patients also went to other places such as skilled nursing facilities, long-term hospitals, and inpatient rehab. Listed on the right of the screen are all of the patient comorbidities that we looked at, the most common being diabetes and COPD. However, a large population of patients also had congestive heart failure and renal disease. Here's a breakdown of the different kinds of ventral hernias that we identified in the 1,393 ventral hernias that we found. Majority of them were non-incarcerated, while a very, very small number were actually strangulated. Majority of patients underwent non-op management, and of those patients undergoing ventral hernia repair, majority of those were done open. Listed to the right of the screen is the operative rate for each hernia type. Not surprisingly, strangulated had the highest operative rate. In terms of open versus laparoscopic, as I previously said, 80% of our procedures were done open, and we found that hernia type was not predictive of open versus laparoscopic technique. This slide's similar to the last slide, but it also incorporates the use of mesh. We did find in our study that ventral hernia repair was much more, ventral hernia repair without mesh was much more likely to be done open, and open surgery was associated with more bowel resections. However, lysis adhesions was actually similar between open and laparoscopic procedures. On univariate analysis of operative management, patients undergoing operative management tended to be younger, female, and with fewer medical comorbidities. We found no difference in the BMI between these two groups, and we found that there were some specific medical comorbidities that were associated with increased non-operative management, but in general, having higher medical comorbidities was associated with higher non-operative management. On univariate analysis of open versus laparoscopic ventral hernia repair, we found that patients undergoing open repair were more likely to be older, have more medical comorbidities, and their length of stay was almost double that of a laparoscopic repair. There was no difference in gender or BMI in those patients undergoing laparoscopic versus open ventral hernia repair. Listed here on this slide is the mortality rate at the 5 different time points that we examined in our study. At 3 years out, regardless of ventral hernia type or repair, the mortality rate was 23%. When looking at our mortality rate specifically at 30 days based on ventral hernia type, we found that incarcerated and non-incarcerated hernias were statistically significant for both of these. Incarcerated hernias were more likely to be alive at 30 days, while non-incarcerated hernias were more likely to be deceased at 30 days. When looking at operative status, we found that undergoing operation resulted in a statistically significant decrease in mortality, while undergoing non-operative management actually resulted in statistically significant increase in mortality. The ventral hernia repair method that was used, whether that incorporated mesh or whether it was open or laparoscopic, ventral hernia repair without mesh was found to have a statistically significant decrease in 30-day mortality, as well as open ventral hernia repair with mesh. On multivariate analysis of mortality at all time points, there were 3 things that came up in our analysis as statistically significant, and that was Charleston Comorbidity Index, resuscitation, and operative repair. Charleston Comorbidity Index was found to be increased mortality. Odds ratios are listed here at all time points. Resuscitation, meaning any patient that came in with a diagnosis of sepsis or any diagnosis that required a medical resuscitation, was also shown to increase mortality at all time points. However, undergoing operative repair was shown to decrease mortality at all time points, while undergoing non-operative repair was shown to increase mortality at all time points. In conclusion, the rate of emergent ventral hernia repairs in prior studies has been quoted around 10 to 12%. However, in our study, we found that it's up to 40%. Patients with emergency or urgent ventral hernia complaints are more likely to be older, female, have obese BMIs, as well as increased medical comorbidities. This is associated with increased non-operative management, use of open technique, and increase in 30-day mortality. Non-operative management is associated with increased mortality at all time points except inpatient. This is a call for surgeons to be judicious about non-operative management. Could these patients have died of something else that led the surgeon not to operate while they were inpatient, which explains why the operative, odds ratio was not significant while they were inpatient? Open ventral hernia repair is associated with an increase in mortality more than laparoscopic ventral hernia repair. However, could there be an inherent bias in choosing sicker patients with more medical comorbidities to undergo open ventral hernia repair, which results in an increased mortality? Or could it be because patients undergoing open ventral hernia repair were more likely to be in extremis? Only 52.9% of repairs involve the placement of mesh. This could be from a multiple list of confounding factors, such as surgeries requiring bowel resection, hernia defect size, multiple hernias at the time of repair, and damage control surgery. Limitations of our study involve only the use of ICD-9 codes. We are unable to currently link several billing points from our EMR, which we hope to link for future studies. And we could use this to track patients, estimate risk of adverse outcomes, and early identification and triage of patients to appropriate facilities. Thank you for your time and listening.